Hello, dear students. I am Dr. Mushfig Orujov, the Associate Professor of Department of Pathological Anatomy of Azerbaijan Medical University. Today, we have a lecture on following topics about the gingival and periodontal diseases, such as the gingivitis, parodontosis. Then we have discussing about the inflammatory diseases of the oral mucosa, such as the stomatitis, cheilitis, and glossitis. Then disease of jawbones, the periodontitis and osteomyelitis. And finally, we have discussion about the disease of salivary glands, as well as the sialadenitis and sialolithiasis. First, let us start from the gingiva, or we call it as a gum, and from the normal histology and anatomy, you know that is divided. It is the part of the oral mucosa that covers the alveolar processes of the jaws that protect the underlying tissues. It is divided anatomically to three parts as the interdental gingiva, the marginal gingiva, and attached gingiva. The gingivitis is an inflammation in the gingiva associated with the presence of oral microorganisms in the gingival sulcus. There are four types of gingivitis depending on the course and the distribution. First, the acute gingivitis. It is of the sudden onset and a short duration. It can be painful. The subacute gingivitis is a less severe phase of acute infection. Then recurrent gingivitis, the reappears either after treatment or disappears spontaneously. And chronic gingivitis is showing onset of long duration, usually painless and the most commonly occurring gingival condition. Depending on the degree of severity, mild, moderate, and severe forms of disease are distinguished. Depending on the nature and pathological anatomic features of the inflammatory process, there are three types of the gingivitis are distinguished. First, the catarrhal ulcerative gingivitis, and chronic gingivitis. Catarrhal gingivitis is more common and accounts for about 90% of all gingivitis. There are acute and chronic catarrhal gingivitis. Acute catarrhal gingivitis is usually found in children and often develops as a symptom of acute respiratory infections. Chronic catarrhal gingivitis is most often found in young, middle, and elderly people with pain and other subjective symptoms. The bleeding from the gums is the main clinical signs, especially when during the cleaning the teeth. In the gingiva, we can find the signs of the inflammation, such as the hyperemia, edema, swelling, and the development of the loose connective tissue. And also, we can find the small foci of the lymphohistiocytic infiltration. In this illustration, we do the gross view of the gingivitis. Also the histopathological findings during the gingivitis. Here we see the lymphocytes and the plasma cells in the connective tissue. Ulcerative gingivitis also has the acute and chronic course, such as the catarrhal gingivitis. So unlike to the catarrhal gingivitis, the ulcerative gingivitis is very rare and is accompanied by symptoms such as the multiple bleeding from the gums, acute pain in the mouth, and the unpleasant odor, so difficulty in food intake and fever. This type of the gingivitis also called as Vincent's necrotizing ulcerative gingivitis. The main morphological signs is the predominance of alterated tissue change, especially the necrotic change, and not oxidate catarrhal change in the area of inflammation. This necrotic change often begin at least from the back of the teeth and sometimes from the palatal tonsils during Vincent tonsillitis. Under the microscopy, we will find the erosions in the gums, necrotic plaque, edema, lymphocytic infiltration, acute hyperemia, atrophic change in the epithelial tissue, and the bacteriological examination will give us the large number of the Borrelia vincenti and fusiform bacilli, actinomyces, and chromomyces under the necrotic plaque. Here we do the acute, the gross description of the acute necrotizing ulcerative gingivitis and histological findings. Here we see the hyperemic microcirculatory blood vessels together with the severe lymphohistiocytic infiltration. Chronic gingivitis can be catarrhal, hypertrophic, and atrophic. Chronic catarrhal gingivitis can occur in the form of occasional swelling and redness in the gums. It is characterized for a long period of sluggish flow, but complaints are mild. The inflammatory process may be limited to the interdental papilla and marginal gingiva, or covers the entire alveolar part of the gums, is limited, localized, and generalized. Chronic hypertrophic gingivitis is manifested by overgrowth of the gum tissue, thus increasing the interdental papilla, which can cover the entire outer surface of the tooth. Appears pain when eating and bleeding gums. In the long course of any form of gingivitis can occur in the atrophic gingivitis. The gums become thin, atrophies, and easily injured during chewing. The most common form of gingival disease, chronic gingivitis, is universal in distribution. It is caused by a local irritation such as plaque, calculus, or pure restoration, and occur in two forms, the edematous and fibrous types. So in the edematous type, the gingiva is enlarged and glossy, loses its stippling, and bleeds easily. Microscopic examination reveals that keratinized stratified squamous epithelium, which normally covers the gingiva, either is unaltered or shows absence of the keratin layer. The fibrous type of chronic gingivitis is a later stage of the edematous type that characterized by enlarged firm gingiva that may bleed during tooth brushing. Microscopically, the prominent feature is the formation of fibrous tissue, but also plasma cells and lymphocytes are present in various amounts. Atrophic gingivitis can be any particular gums and can spread throughout the entire gum. Thus, interdental papilla often completely absent, and the gum becomes smooth character. Atrophic gingivitis is a constant source of infection in humans and can cause exacerbation of chronic diseases of internal organs. So here we do the types of the chronic gingivitis, the localized, as we mentioned, the generalized, the localized gingivitis is confined to the gingiva of a single tooth or group of teeth less than 30% of surfaces. But the general gingivitis involves the entire of the mouth. And here we see the distribution of inflammation during the chronic gingivitis, papillary, marginal, and diffuse types. The marginal gingivitis involves the gingival margin. The papillary gingivitis involves the interdental papilla, often extend into gingival margin, and early signs of gingivitis find. And diffuse gingivitis affect the gingival margin, the attached gingiva, and the interdental papilla. Here we do the anatomical findings during the localized and generalized types. Also, the gross view of the gums during the generalized chronic papillary gingivitis, during the localized chronic diffuse gingivitis, and localized chronic diffuse gingivitis in the area of upper lip maxillary teeth. Now we have discussion about the parodontosis or the periodontal disease. Parodontosis is a disease of the structures surrounding and maintain the teeth. It includes the gums or the gingiva, ligaments, alveolar bone, cementum. Parodontosis is the second most common disease of the oral cavity, right after defect. It is usually develops generalized. Main change occur most often in the lower or in the cutting and canine teeth areas of both jaws. The etiology of parodontosis is not exactly known. But there are background diseases of parodontosis, such as the long-term nervous situation, cardiovascular system diseases, metabolic disorders, some endocrine diseases, rheumatic diseases, diabetes mellitus, hormonal disorders of the reproductive system, etc. Parodontosis is often found in combination with dental diseases of non-carious origin, such as the cuneiform defect, hyperesthesia, erosion of the enamel, etc. Here we see the gross description of the parodontosis. The pathogenesis of the parodontosis, first, the inactive form of resorption occurring in the interdental bone alveola. The trabecula thicken as the process of renewal of bone structures, especially spongy material. Its normal histological structure is disrupted. Multiple osteoporosis, osteonecrosis, and osteosclerosis foci form. As the resorption of bone alveoli deepens and the periodontal fissure expands. Gums also decrease in volume and backward retraction occurs. First, the neck of the tooth, then gradually the apex of the root is opened. Aesthetic defect occurs in the patients. Even during the third, fourth degree of resorption of the bone alveoli, this process occurs with the retraction of the gums. They do not break through the tooth socket. Despite resorption, the apex of the alveolar process is hard. In the bone marrow are observed the mesenchymal degenerative change, mucoid swelling in small caliber vessels, fibroid change, hyalinosis and sclerosis, narrowing after lumen, even ear obliteration. Number of capillaries decreases. So the mesenchymal dysparthenosis and vascular change also found in the gingival tissue. When parodontosis is accompanied by secondary inflammatory process, corresponding change occurring both morphological and clinical signs. Here we see the healthy tooth with the parodontosis. That here we see we do the reduction of the interalveolar bony trabecle and formation of the socket. There are three types of the periodontosis: the mild, moderate, and severe, depending on the intensity of clinical morphological symptoms. Now, let us discuss about the inflammatory disease of the oral mucosa. Stomatitis is the inflammation of mucous membranes of the soft tissues of oral cavity, such as the cheek, soft and hard palate, the floor of oral cavity. It is the most common disease in the dental practice. It is occurring in all age groups. Stomatitis can develop in the oral cavity, both is an isolated form and in combination with inflammation of the mucous membranes of other oral organs, gingivitis, cheilitis, and glossitis. Now you see the classification of the stomatitis. Depending on the clinical course, there are acute and chronic stomatitis, depending on the characteristics of morphological change, serous, catarrhal, fibrinous, purulent, and gangrenous stomatitis has been distinguished. Depending on the depth of the pathological change, there are superficial and deep stomatitis. So appearance and morphological features of the inflammatory focus in stomatitis are the ulcerative, desquamative, catarrhal ulcerative, catarrhal desquamative, apostomatous, macular, vesicular, nodular, Aphthous, erosion, and etc. But new classification is found that traumatic stomatitis, infectious stomatitis, allergic stomatitis, stomatitis which occurs as a result of exogenous intoxications, stomatitis which develop as a result of various pathologies of individual organs and systems, and stomatitis which occurs during some dermatosis. Aphthous stomatitis. What means the aphthous? Aphthous is an oval-shaped erosion with gray-colored fibrinous exfoliative plaque covered with a thin red burden. Stomatitis accompanied by the formation of aphthous is called Aphthous stomatitis. It is usually painful, prone to the chronic course and reservation. Aphthous stomatitis is widespread among the population, is more common in children and adolescents. The etiology of Aphthous stomatitis is not known exactly. Etiopathogenesis of Aphthous stomatitis include the psycho-emotional nervous tension and stress, autoimmune and hypersensitivity reactions, chronic recurrent septic allergic reactions, pregnancy, infections, especially streptococci and staphylococci, and etc. Here we see we do the Aphthous stomatitis, the gross description of the Aphthous stomatitis, the Aphthous ulcer on the buccal mucosa, and histopathological findings, the non-specific mixed submucosal inflammation underlying the epithelial ulceration is seen. The traumatic stomatitis caused by mechanical factors, high and low temperatures, irradiation, chemicals, the medicinal substances called as the medicamentous stomatitis, acute or chronic effects of meteorological factors. It occurs mainly as a result of the effects of local pathogenic factors and is the most common among all stomatitis. Infectious stomatitis occurs freely as a result of the action of some pathogenic microorganisms, especially herpes viruses, bacteria, fungi, spirochetes. For example, Vincent ulcerative necrotic stomatitis, which develops as a result of the action of Vincent's spirochetes and fusobacteria. If this disease is localized only in the gums, it is called ulcerative necrotic gingivitis or Vincent's gingivitis. If it is localized in the palatine tonsils, we call the Vincent angina. In some cases, infectious stomatitis develops as one of their morphological signs or complications. during various acute and or chronic infectious disease, including the venerals. The pathogenesis of allergic stomatitis is immediate or delayed immune reactions. It can occur as a result of the direct effects of allergens of different nature and chemical compositions. For example, the medicaments, toothpaste on the oral mucosa. The allergic stomatitis, also called as the contact allergic stomatitis. Sometimes it also develops as a sign of various allergic or toxic allergic or autoimmune diseases, for example, rheumatic diseases. Next type of stomatitis is stomatitis, which occur as a result of exogenous intoxications. This group also includes the professional stomatitis. Stomatitis, which develops as a result of various pathologies of individual organs and systems, as well as various metabolic disorders, for example, avitaminosis, endocrine diseases, disease of the gastrointestinal tract, pregnancy pathologies, disease of the blood system, and etc. Stomatitis, which occurs during some dermatosis, for example, during dermatitis. Now let us discuss about the cheilitis. Cheilitis is the inflammation of the lips. From a nosological point of view, cheilitis can occur both in the form of free disease as well as in stomatitis as one of the morphological signs of various other diseases. As a symptom, cheilitis are more common, especially in combination with stomatitis and skin diseases. There are acute and chronic cheilitis according to the clinical course and independent and symptomatic cheilitis according to the clinical and morphological features. The independent or the nosological or special cheilitis include the exfoliative cheilitis, glandular cheilitis, contact or allergic cheilitis, actinic cheilitis, and meteorological cheilitis. Symptomatic cheilitis include atopic cheilitis, exogenous cheilitis, plasma cell cheilitis, macrocheilitis, and Minganoti cheilitis. Exfoliative or factitious cheilitis, also called the exfoliative cheilitis of Mikulicz Kummel. Exfoliation of the skin is called pathological process characterized by the peeling of its surface layer, squamous stratified epithelium, from the lower layers in the form of leaves. So also etiology also is not exactly known. The role of mental emotional tension, hyperthyroidism, genetic, immunological, and other factors in the occurrence of the disease has been determined. The disease is localized only on the vermilion border of the lips. It is most often found in women. There are two forms or two types. It is able to develop dry and exudative. In the dry form, with a chronic and prolonged course, hyperkeratosis and acanthosis occur and scales are formed. In the prognostically mild exudative form, vascular reactions, acute hyperemia, edema, and other exudative changes are predominant in the tissue. Here we do the gross description of the exfoliative cheilitis and histopathological description. This is the photomicro of an incisional biopsy taken from a lower lip of a 44 years of human, and showing oral mucosa exhibiting keratosis with minimal chronic inflammation. Glandular cheilitis usually develops after 50 years of age, most often on the lower lip. It is characterized by hereditary anomalies of the small salivary glands, heterotopia of parenchyma, located in the vermilion border of the lips and in the cline line zone where the red border passes into the mucous membrane, hypertrophy, and infection. Glandular cheilitis can develop both primary and secondary as a symptom of other diseases such as the leukoplakia, systemic lupus erythematosus, and etc. Here is the histopathology of the glandular cheilitis, the chronic inflammation, fibrosis, and oncocytic metaplasia of the ducts, and some of the acini is shown here. Contact or allergic cheilitis occurs as an allergic reaction of delayed type as a result of the direct effect of various allergic substances on the vermilion border, especially in the middle or elderly women. The main clinical and morphological signs are redness, edema and swelling in the vermilion border, hyperplasia and inflammation of the glandular structure, itching, pain, small vessels and erosion and fissure formed in their place. Actinic cheilitis occurs as a result of the influence of ultraviolet rays on the background of high sensitivity to the sun's rays. It's usually found in the spring, summer season in the persons older than 20 years, especially in men. It has exudative and dry forms. The clinical and morphological course of the exudative form is similar to that of contact dermatitis. Dry form of actinic cheilitis include the clinical signs such as the dryness, burning and pain, redness, pale gray color, small hyperkeratosis, and acanthosis foci on the lip. Here is the gross description of the actinic cheilitis that diffusely involves the lower lip with associated crusting, and histopathology of the actinic cheilitis. Here we see the mucosal acanthosis with overlying hyperkeratosis, and there is a irregular budding and basilar atypia with the cells that show the enlarged hyperchromatic staining nuclei. Meteorological cheilitis occurs as a result of influence of natural meteorological factors such as the wind, cold, humidity, especially in the colder months. At this time, on the vermilion border of the lip develops dryness, wrinkles, redness, small hyperkeratosis, and weak lymphocytic infiltration of the stroma. Atopic cheilitis occurs during atopic dermatitis or neurodermatitis of allergic origin, whether it is from secondary developing cheilitis. Pathological change developed not only on the vermilion border, but also on the cutaneous part that surrounds it. Eczematous cheilitis develops as one of the symptoms of eczema of a nervous allergic nature. There are acute and chronic course of the eczematous cheilitis that characterized by swelling of one or both lips due to prolonged and persistent edema along with other areas of the face. Under the microscopy, we will find the edema, vasculitis, microcirculatory disorders, weak lymphohistiocytic and plasmacytic infiltration. Here is the gross pathology of the eczematous cheilitis you see. Menganotic cheilitis usually occurs in men over the age of 50 against the background of trauma, ultraviolet rays, sometimes of herpes viruses, and the influence of pathogenic factors. In the middle part of the lower lip, against the background of chronic catarrhal inflammation and hyperemia, one or more erosions, covered with a bloody scab are developed. The scab is difficult to break and tends to bleed when it is broken. The process is chronic, lasts from several months to many years. The inadequate treatment causes malignancy and cancer. For this reason, meningotic cheilitis is considered a precancerous process. Therefore, it is also called meningotic precancerous abrasive cheilitis. Now let me discuss about the inflammatory process of the tongue that we call as the glossitis. According to the nosology, it can develop both primary and secondary glossitis. Symptomatic or the secondary glossitis occurs as one of the morphological changes that develop during other inflammatory diseases of the oral cavity, including disease of other organs and systems. For example, deficiency of group B vitamins, diabetes mellitus, disease of the GI tract, the Sjogren's syndromes, Hunter glossitis developed as a result of B12 deficient anemia, and etc. In addition to the superficial inflammatory change that occur in the mucous membrane, inflammatory processes of various nature such as abscess, phlegmon, actinomycosis are also found in the deep layers of the tongue. There are acute and chronic glossitis are distinguished. The relatively common forms of primary glossitis are the desquamative and rhomboid glossitis. Desquamative glossitis is more common, has a chronic course, even lifelong. The etiology is not exactly known. The presence of a hereditary pathology is not excluded. The desquamative glossitis characterized by small foci desquamation of papillary epithelium of the mucous membrane of the tongue and their regeneration in the form of foci. Therefore, it is called geographical tongue because it resembles exfoliative glossitis or geographical map. The tongue gets a strange external appearance. Under the microscopy, we will find the reduction of mucous membranes in these areas, atrophy and desquamation of the epithelium, parakeratosis, pure edema of the mucous membrane, and lymphohistiocytic infiltration. We do the geographical map or the gross anatomy of the desquamative glossitis and the histopathological view of the desquamative glossitis. Rhomboid glossitis, the upper surface of the tongue in the middle line does not have mucous membranes in the limited rhomboid or oval-shaped area in which papillomatous structures develop. The color is red or pink. The surface is often smooth and sometimes rough. It is about 1 to 2 centimeters wide and 1 to 5 centimeters in length. The etiology also is not yet known exactly. Some groups of scientists consider that the rhomboid glossitis is the developmental anomaly of the tongue. Others report its occurrence as a result of infection as chronic candidiasis. Rhomboid glossitis has a chronic course and lasts for many years. It is most often found in the males, especially in smokers. In rare cases, the malignancy of rhomboid glossitis may occur. Here is the gross anatomy of the median rhomboid glossitis. Black hairy tongue is benign condition of the dorsal tongue characterized by elongation and often staining of the filiform papilla due to the action of chromatogenic microbes imparting a hairy appearance. Also, the brown, green, or yellow discoloration may be present. Each mucosal papilla located approximately in the middle of dorsal tongue in the form of a triangular or oval-shaped focus is only elongated to about 2 cm and thickened to 2 mm. The reason of the thickening of lingual mucosal papilla is the desquamation of these squamous epithelial cells. This disease, whose etiology is unknown, is most often found in smoking men. Here is the gross anatomy of the black-haired tongue. Here you see the black-haired tongue associated with bismuth staining and brown-haired tongue associated with smoking. And this figure demonstrates the histopathology of the black-haired tongue that mark elongated of the filiform papilla with hyperkeratosis and superficial basophil bacterial colonies we see here. Now let us discuss about the disease of the jawbones, inflammatory disease of the jawbones. Disease of the jawbones due to the etiopathogenetic, clinical, morphological, and pathological nature are divided into different groups. Inflammatory disease of the jawbones as well as the facial-maxillary region are divided into several groups depending on the source of the spreading of the pathological process: odontogenic, autogenous, tonsillogenic, hematogenous, rhinogenous, etc. The inflammatory process of odontogenic origin developed in the facial-maxillary region are considered one of the most common examination objects of surgical dentistry. Among this group of disease, the most common are chronic periostitis, acute and chronic periodontitis, osteitis of the jawbones, acute and chronic osteomyelitis, abscess and phlegmonous process of soft tissues of the jaw, lymphangitis, lymphadenitis, adenophlegmon, and other pathologies. The main etiological factor in the occurrence of inflammation of the jawbones as well as soft tissues of the jaw is microbial association, consisting of gram-negative and gram-positive bacilli, streptococci, and staphylococci. All inflammatory odontogenic diseases take their origin from the acute and chronic apical periodontitis. Organ-specific oncological diseases of the maxillofacial area are found in about 1 of 7 to 8 patients in surgical dental practice. Due to anatomic localization, these diseases are divided into 3 groups. First, odontogenic tumors. Second, tumors of salivary glands, and tumors of the oral mucosa. Due to character, they are divided to 3 groups: benign and malignant tumors, tumor-like formation, and cyst. The most common organ-specific oncological disease and neoplasm of the maxillofacial region are odontogenic and non-odontogenic cysts of the jawbones, fibrous dysplasia, tumor-like formations such as cherubism and eosinophilic granuloma, odontogenic and non-odontogenic benign and malignant true tumors. Periostitis is inflammation of the periosteum of the alveolar process of jawbones. According to the clinical course, all periostitis are divided into 2 groups: acute periostitis and chronic periostitis. Acute periostitis is usually found in young and middle-aged men, especially in the lower jaw and the level of the large molars and wisdom teeth. The process passes to the periosteum through the expanded Haversian or Volkmann's canal during chronic periodontitis, which is most cases are in the acute or exacerbation phase. Infection can also pass through the periosteum through the lymphatic vessels. So the acute periostitis in most cases occur as a complication of periodontitis. In addition, acute periostitis can sometimes occur in cases of traumatic extraction of the tooth, such as the post-traumatic periostitis, suppuration of the radicals, and etc. Serous periostitis is one of the types of the periostitis because depending on the nature of the inflammatory exudate, there are two types of the acute periostitis are distinguished: serous periostitis and suppurative periostitis. The serous periostitis, also sometimes called as a simple periostitis, develops in the initial period of the process that characterized by the hyperemia of the periosteum, edema, focal diapedesis, swelling, weak lymphocytic infiltration, detachment of the periosteum from the bone. In most cases, the process is also aggravated in a short time. Destructive change in the foci of inflammation deepen the concentration of neutrophils rises, serous exudate turn into the serous purulent exudate, and thus the acute suppurative periostitis develops. Suppurative periostitis usually begins in the alveolar process, either medial or lateral side of it. Under the microscope, we can find the further intensification of histopathological change in serous periostitis, appearance of neutrophils and their decomposition products, microbial colonies, mucoid and fibrinode swelling change in vascular walls and connective tissue fibers, focal necrosis of the periosteum, and etc. The reason for the development of necrotic process is the occurrence of thrombosis in microcirculatory vessels in this area, and the interruption of blood supply is in that tissue part. So the development of the infection. Sometimes, due to the solid structural features of the bone tissue, the purulent process cannot be widely spread, and under the bony tissue, as a small focus of pus is formed. So we call it the subperiosteal abscess. The process becomes more progressive and can spread to surrounding areas. In this case, the bone and surrounding soft tissue are subjected to purulent lesions. The purulent process passes in the form of a canal into the oral submucosa and opens out of the oral cavity through the skin after 5-6 days. Or the purulent process resorbs bone tissue, spreads to the jawbone itself, or it is bone marrow, leading to the development of secondary suppurative osteitis or osteomyelitis respectively. During the acute suppurative periostitis, in addition to the above-mentioned local change, perifocal change and other clinical signs appear in nearby soft tissue, including in the regional lymph nodes. Perifocal change in soft tissue are caused by their hyperemia, acute edema, swelling, and pain. Chronic periostitis is rare. It can often develop as a complication of acute periostitis, sometimes as a primary disease, especially in children. Usually occurs in the lower jaw as a long-term course. The inflammatory process is proliferative in nature. In addition to proliferative inflammation in the same area, the development of connective tissue, or fibrosis, and this gradual bone formation ossification occurs in the periosteum and resorb contact bone tissue. Therefore, it is sometimes called chronic proliferative periostitis or chronic hyperplastic periostitis. In this area, the bone tissue thickens and becomes somewhat rough. Osteomyelitis is inflammation of the bone marrow of the jawbone. In general, osteomyelitis, due to their origin, are divided into 3 groups: odontogenic osteomyelitis, hematogenous osteomyelitis, and contact osteomyelitis. Odontogenic osteomyelitis is an infectious purulent necrotic inflammation of the bone marrow of the jaw, which is almost all cases is secondary. It occurs as progression of acute purulent periodontitis or complication of chronic periodontitis. Psychoemotional tension weakens of the body's immune system, increased sensitivity to pathogenic microflora, and other important common factors also play a big role. For this reason, as in periodontitis and periostitis, it is most common in men, young and middle-aged people. Odontogenic osteomyelitis usually occurs in the lower jaw at the level of large molars and wisdom teeth, especially in the bony alveolar process. The etiology is mainly staphylococci and streptococci, gram-negative and gram-positive bacilli, and etc. In very few cases, osteomyelitis can also occur as a result of the suppression of apical cyst or other pathological processes. Classification of odontogenic osteomyelitis. According to the clinical signs and duration, three forms of odontogenic osteomyelitis are distinguished: acute osteomyelitis, subacute osteomyelitis, and chronic osteomyelitis. These forms are also considered to be the successive stage of this process. After 10-14 days of acute osteomyelitis passes into the subacute osteomyelitis, but after about 25-35 days, it passes into chronic osteomyelitis. Depending on the spread of the process, two types of the odontogenic osteomyelitis are distinguished: local odontogenic osteomyelitis and diffuse odontogenic osteomyelitis. Local odontogenic osteomyelitis is the inflammation of the alveolar process and the shaft of the jawbone in 3-4 tooth level. Diffuse odontogenic osteomyelitis, purulent inflammation of the jumbo in half or whole. Acute osteomyelitis. The pathological change in acute osteomyelitis develops both in the bone marrow and in the bone tissue, as well as in the contacting bone and nearby surrounding soft tissue. So passing of suppurative inflammatory process from the periodontium to the alveolar process, causing inflammation of the bone tissue, osteitis. In a very short time, passing of process to the bone marrow of the alveolar process and the body of the mandible. Formation of separate and small purulent foci of inflammation. Formation of the relatively large purulent area as a result of the combination of these foci of inflammation, and appearance of thin bone trabecula in the inflammatory zone as a result of lysis, resorption of the bone tissue. Then, development of necrotic change of bone tissue in this area of the inflammation due to microcirculatory disorders. Formation of necrotic but not post-necrotic autolysed bone sequestra. Therefore, the cavity formed due to resorption in the purulent inflammation area is also called the sequestral cavity. Passing of inflammatory change from the bone marrow to the nutrient canals of the bone, which leads to the vascular change, serose and suppurative inflammatory change in the wall of the vessels and in the perivascular spaces, and finally to necrosis and destruction of the anterior canal contents. Here we see the histopathology of the acute osteomyelitis. So abundant the neutrophil infiltration is seen here. If the process is of a chronic nature, the walls of the sequestral cavity, like the walls of the chronic abscess, are made up of three layers: inner pyogenic layer or the pyogenic membrane, middle granulation tissue layer, and outer fibrous tissue layer. Sometimes the sequestral cavity wall also undergo to purulent lysis in some parts, leading to opening of purulent canal from the sequestral cavity, to the oral cavity or to the face through the skin. Chronic osteomyelitis is sometimes accompanied by exacerbation. Here is the histopathological illustration of the chronic osteomyelitis. The irregular fragment of devitalized bone is seen. So the surrounding by dense fibrous tissue, which is infiltrated heavily by lymphocytes, plasma cells, and few granulocytes. Depending on the nature of the change in the inflammatory focus and the predominance of the change, as well as the characteristic of the clinical course, three clinical variants of chronic osteomyelitis are distinguished. First, destructive or necrotic osteomyelitis, also called the sequestrating osteomyelitis, destructive proliferative osteomyelitis, and proliferative osteomyelitis, also called hyperplastic or hyperostosis osteomyelitis. Now let's discuss about the disease of the salivary glands. Disease of both large and small salivary glands are divided into two parts, congenital and acquired. More clinically significant and more commonly acquired diseases, depending on the nature of the pathology, are divided into three groups. First, sialosis or sialadenosis. These are the degenerative or reactive degenerative disease of the salivary glands. For example, hypersalivation, hyposalivation, Mikulicz disease and syndrome, Sjogren's syndrome, and etc. Second group is sialadenitis. It is the inflammation of the salivary glands. Acute and chronic sialadenitis, various types of them, including calculous sialadenitis, sialolithiasis, chronic sialadenitis, and etc. are distinguished. And finally, oncological disease of the salivary glands. That group include the true tumors, tumor-like formation, and cysts of the salivary glands. Acute sialadenitis is the acute inflammation of the salivary glands. The inflammation of the parotid glands is called the parotitis. Depending on the etiology, very often it is infectious, sometimes traumatic, toxic. Acute sialadenitis of infection origin often develops as a secondary manifestation or exacerbation of some infection. It's rare cases it develops as a primary and characteristic localization. For example, epidemic parotitis, cytomegaloid, etc. Depending on the nature of the inflammatory process, serous, suppurative, and gangrenous sialadenitis are distinguished. Etiopathogenetic classification of acute sialadenitis. They include the epidemic parotitis, influenza sialadenitis, acute bacterial sialadenitis, lymphogenic sialadenitis, contact sialadenitis, and acute sialadenitis occurring as a result of entering a foreign body into the salivary glands. Epidemic parotitis is an acute infectious disease of the parotid glands of viral origin. Influenza sialadenitis develops as a complication of influenza. It can be found in all large and small salivary glands, especially in the parotid glands. Acute bacterial sialadenitis develops during many bacterial infections, typhoid fever, epidemic typhus, etc., and as a complication after some surgical operations. These are also called post-infectional or post-surgical sialadenitis. Lymphogenic sialadenitis occurs as a result of the spreading of infections from nearby tissues of the lymphoid apparatus of the parotid gland by lymphogenic ways. Contact sialadenitis develops as a result of the direct contact of the infections during the purulent inflammation of nearby organs and tissues directly into the parotid glands or other large salivary glands. And finally, acute sialadenitis occurring as a result of entering a foreign body into the salivary glands. Chronic sialadenitis, this is the purulent inflammation of the salivary glands, characterized by diffuse inflammatory change in the glandular tissue and the development of connective tissue, development of the sclerosis. Most often occurs in the parotid glands. Etiopathogenesis include general and local factors. General factors is the autoimmune pathologies such as the weak immune system or Sjogren's syndrome, and local factors is a congenital structural defect of the salivary glands. Classification of the chronic sialadenitis. Depending on the degree of intensity of clinical symptoms, there are two types of the chronic sialadenitis. Chronic sialadenitis with acute active course and with inactive course, for the exacerbation phase and remission phase. Depending on the histological localization of the inflammatory process in the glandular tissue, there are three stages: initial stage, clinically manifested stage, and later stage. All chronic sialadenitis are divided into three groups: parenchymatous sialadenitis, interstitial sialadenitis, and ductal sialadenitis. But despite this division, interstitial proliferative inflammation during all chronic sialadenitis develops to some extent. Now let me discuss about the parenchymatous sialadenitis. The process of chronic inflammation in parenchymatous sialadenitis is mainly localized in the parenchyma of the parotid gland in its glandular structures. It is also called chronic recidivating or chronic recurrent parotitis. Usually it can be bilateral, sometimes even one-sided. The main causes of the development of the parenchymatous sialadenitis are congenital cystic expansion and dysplasia of the secretory portion of the parotid gland, disorder of salivation and congestion, fall of infection through the ducts, development of chronic inflammation. Pathological change involve all tissues of the gland with the predominance of secretory portions in the parenchyma. Ducts are dilated and thickly homogeneous masses appear in the lumen. The epithelium of the acini undergoes the parenchymatous perateinaceous degenerations. Around the ducts and other parts of the interstitium develops the connective tissue in the form of small lymphohistiocytic infiltrates, foci, and bands. All this leads to the gradual deformation of the secretory portion and ducts of the glands, and sometimes to its diffuse sclerosis, and finally to the weakening and loss of function. Like other types of chronic sialadenitis, parenchymatous sialadenitis is accompanied by periodic exacerbations. Here is the histopathology of the chronic sialadenitis. We see the patchy lymphocytic infiltrate and fibrosis in the stroma. Interstitial sialadenitis, characterized by the predominance of the chronic inflammatory process in the stroma of the salivary glands, is so-called chronic proliferative, sclerosing, or atrophic sialadenitis, or symptomatic sialopathy, or secondary infected sialosis. Most often it is observed in older women. In contrast of parenchymatous sialadenitis, the main causative factor in the etiopathogenesis of interstitial sialadenitis is the effect of a general factor, metabolic disorders, such as the diabetes mellitus, cardiovascular diseases, digestive tract diseases on the organism. In the stroma of the salivary glands, diffusely are developed connective tissue and adipose tissue. The stroma is infiltrated with lymphohistiocytic elements. Some secretory portions and the ducts are collapsed, replaced with sclerosis and lymphoid cells. At first, the glands, which are equally swollen and grow in a volume, gradually become sclerosed and undergo to the lipomatous atrophy. Here is the photomicrograph of to demonstrate the histopathological finding in the during the interstitial sialoadenitis. This biopsy taken from the sublingual gland that show the diffuse lymphoplasmacytic infiltration with acina degeneration, dense fibrotic tissue fibrosis, and ductal dilation in the absence of the sialoid formation. Ductal sialoadenitis or chronic sialodochitis, also called as the fibrinous sialoadenitis. Some group of scientists consider this is a special developmental variant of parenchymatous sialoadenitis, but others as a senile sialoadenitis. Most often it is found in elderly people. That disease begins as a result of the congenital dilatation of ducts of salivary glands. The ducts of salivary glands are ectatic. Large amount of desquamated epithelium, lymphohistiocytic infiltration with the neutrophil mixture, filiform fibrin fibers in the ductal lumen are found. Also, the metaplasia we can find in the ductal epithelium. So sometimes the lumens of the ducts becomes occluded, obliterated with mucus or fibrinous plaque. Now let me discuss the sialolithiasis. The stone disease of it is the stone disease of the salivary gland. It is the deposition of stones in the salivary gland, or rather in their secretory and ductal parts. It is observed in all age groups and the both sexes, especially in men of middle age. Most often, the sialolithiasis is found in the submandibular gland and sometimes in the parotid gland. Pathogenesis include two kinds of factors: the general factors such as the metabolic disorders, avitaminosis, and local change, inflammation, especially non-specific bacterial sialoadenitis, congestion, dyskinesia of the ducts, and etc. The salivary stones can be from a fine powder size up to 2 centimeters in diameter. The stones are oval in the secretory portion and elongated in the ducts. Usually, the surfaces are smooth. The colors are gray or yellowish. The consistency is soft or solid. Here we see the radiology of the sialolithiasis and the gross anatomy of the sialolithiasis. The clinical symptoms of the sialolithiasis include the following. The first and main clinical signs is swelling of the glands due to the swallowing of the saliva, especially during the eating, the appearance of an unpleasant sensation, and even pain in the glandular area. If the stone is not removed in time, the purulent inflammation develops in the glands and it is dark due to the congestion of the saliva and the joining the infections. Then it is caused to chronic sialoadenitis, hypofunction of the gland, deformation of the duct, sialodochitis, which is exacerbated periodically. So our lecture is finished. Thank you very much for your attention.